Hello guys, hope you're all okay. You're all enjoying your life and also enjoying watching my videos. Hope everything is alright on your part. Welcome back to Dr. Arshad Nadeem Awan Ultrasound teaching videos. Today my topic of discussion is related to thyroid categories. For the classification of the thyroid nodule, U system is proposed by the UK radiologist and by the UK British Thyroid Association, so that is BTA. So they propose U classification which confirms whether the thyroid nodule is benign. If there is no nodule at all in the thyroid, so it will be considered as U1, and if there is benign nodule, so that would be called as U2, and if it is indeterminate for cancer, so that would be called as U3 nodule, and U4 nodule would be suspicious for the cancer, and U5 would be definitely or clearly malignant nodule. So far the difference between the thyroid and the U classification is concerned, U classification is much more sensitive than the thyroid, so therefore U classification is widely used, as it is based on ultrasonography, and you can pick all that information very confidently, very clearly, and it's quite easy to pick, so it needs just a revision. So these consecutive slides will show you how we will label the U classification, the malignant and indeterminate, and the simple and the benign one, and what would be the next strategy. So let's start watching these images for the U classification of the thyroid nodules. Before going to start about the thyroid nodules classification, it is important to have a look for the normal thyroid anatomy. Let's start from the midline. In the midline, you may be able to see trachea having a dirty shadowing because of the presence of the air. On the top of the trachea, you may be able to see isthmus. Isthmus should have been less than 0.4 millimeter, that is the normal size of the isthmus. Towards the right, this is the right lobe of the right lobe of the thyroid, and on the left, this is the left lobe of the thyroid. The most important thing related to thyroid and the thyroid nodule is you have to look for the echogenicity of the thyroid lobe and compare it with the nodules. So there are multiple parameters applied for the comparison purpose. Just on the top of the lobe, you can appreciate strap muscles. Strap muscles happens to be hypoechoic as compared to the right lobe or left lobe echogenicity. In the view, you can see towards the medial inner wall there is a carotid vessels, and towards the outer lateral side you can see the jugular vessels. On the top of it, you can see another muscle presence which is called as sternocleidomastoid muscles. So these two are the very important landmark. Whenever you are looking for the nodule, you have to compare the echogenicity with the thyroid lobe itself, and then after that you have to compare its echogenicity with the strap muscles and then other present muscles within the neck. So this is the important thing you have to be keep in your mind. So there is the isthmus of thyroid, and there are right and left thyroid lobe just on the sides of the trachea, and towards the outer side there are vasculature of the neck including carotid and jugular, while on the top you have the muscular, the strap muscles, and the sternocleidomastoid muscles. Inferiorly and towards the left side, esophagus can also be visualized, and the another muscle group which is called as longus coeli can also be seen in the view. Just for the better understanding, have a look here. You can appreciate the trachea which is producing dirty shadowing, and this is because of the presence of the air. You can appreciate the isthmus of thyroid, and there are two bilateral symmetrical size thyroid lobe, while on the top there is strap muscles visible. You can appreciate the difference of the echogenicity between the strap muscles and the thyroid lobe. Thyroid echogenicity is increased than the strap muscles. Then beside these both sides you can appreciate the carotid and internal jugular veins. So these are all the anatomical structure and landmark for the thyroid examination, and especially when you are trying to look for the nodule and applying the classification for the thyroid nodule. So this will help you. The ultrasound U classification of thyroid nodules has been developed by the British Thyroid Association, called abbreviated as BTA, as part of their 2014 guidelines on the management of thyroid cancer. So it allows for the stratification of thyroid nodules as benign or suspicious or malignant based on ultrasound appearance, termed as U1 to U5. There are 5 normal classification, which is starting from U1 and U5 until U5. So far the U1 classification is concerned, U1 classification mean normal. There will be a normal thyroid, there will be no nodularity within it. So it's mean it would be a absolutely normal thyroid, and there will be no nodule in it at all. So you can put the classification as U1. Under the BTA, U2 would be considered as benign. So what would be the characteristic of U2? If the nodule appears to be hypoechoic or isoechoic with a hallo. You can appreciate here, this is the left lobe of thyroid. In the thyroid lobe you can see there is a hypoechoic nodule with a well defined surrounding hallo. That hallo is hypoechoic. This type of nodule would be typically benign, and it would be classified as a U2 benign lesion. So this is a clear example of U2. So it will appear. Compare echogenicity of the nodule with the thyroid gland. It appears to be slightly hypoechoic. Another example here for the better understanding, you can appreciate that this is the left lobe of the thyroid, and in this left lobe you can appreciate 2 nodules. These nodules are well defined, round in shape, and these are slightly hypoechoic as compared to the thyroid nodule echogenicity. The next important characteristic feature, sonographic feature, is both having a surrounding hypoechoic hallo. So this surrounding hypoechoic hallo making it benign. So this is the characteristic of a benign lesion, and you can apply the classification, British thyroid nodule classification, as U2. Multiple characteristics has been discussed for the U2 classification, and as you know that U2 classification is a classification for the benign nodule. If it has any cystic changing within the parenchyma of the nodule with ring down artifacts. If there is any cystic changes within the nodular parenchyma, and if there would have any ring down artifacts, so this most probably be benign nodule, and this would be of colloid nature. Colloid nodules happens to be benign, and these are mostly made up of colloidal constituents and colloidal contents. So because of the colloidal contents, there will be ring down artifacts. This U2 benign nodule clearly explains the presence of the ring down artifact. And the second thing is this nodule is predominantly cystic. So this cystic nodule having the round outline and with internal ring down artifacts, so this is U2 benign lesion, and this would be classified as a colloidal nodule or colloid. This is a characteristic of colloidal nodule, that it is usually appears as a cystic lesion. And the second thing is, if you closely monitor that and look for the internal low level echos or internal contents, so small echogenic foci with having a small tail, that would cause as an artifact, and this would be considered as a ring down artifact. This is the characteristic of the colloidal nodule. So this is the second feature of the U2 benign lesion. This is another U2 classification with the cystic changes and ring down artifacts, and these are typical colloidal lesions. Here you can appreciate this small well defined predominantly cystic nodule within the right thyroid low parenchyma, having a ring down artifact. This is what the ring down artifact is. This is because of the colloidal contents, and histologically it will be proved as a colloidal nodule. So in this scan, so this is on the right and on the left, these both are in the longitudinal and the transverse section, explaining beautifully characteristic cystic nodule with the ring down artifacts, making it a perfect picture for the colloidal nodule. This is slightly bigger nodule, and in this nodule you can appreciate low level internal echos of the colloidal contents, and multiple ring down artifact can also be seen. This nodule is well defined and it is round in shape. No wall irregularity can be seen, and this is setting in the upper pole of the thyroid. This is typically anechoic, and within the lumen the low level internal echos representing the features of the colloidal contents. One of the most important feature of the colloidal content is a ring down artifact. Ring down artifact, or in other word you can call it as a comet tail artifact. Any echogenic foci having a small shadowing connected to it would be considered as either a ring down artifact, or it would be considered as a comet tail artifact. So these both terms can be applied whenever you come across any cystic nodule with the internal contents would be considered as a colloidal nodule, which is benign in nature and should be classified as a U2 classification under British thyroid nodule classification. Still we are looking for the U2 benign classification, having set two important features of the benignicity. The one was a hypoechoic lesion or isoechoic lesion with a hypoechoic hallo, and the second was cystic lesion with a ring down artifact. The third very classical feature which you can appreciate on this imaging is microcystic changes or spongiform appearance. These two words can be used for such type of a lesion. So this is a spongiform appearance. It includes small cystic spaces within the lumen of the nodule. This nodule is well defined, a rounded nodule. Multiple small cystic spaces can be seen, it presenting as like it's a sponge like nodule. So this spongiform nodularity and this spongiform appearance is a characteristic of benignicity. So this is a U2 benign nodule of British Thyroid Association nodule classifications. Have a look to this nodule for the better clarification. This is again microcystic changes within the nodule, and this is also termed as spongiform appearance. If you write microcystic appearance within the nodule, or you apply the word spongiform appearance, which would be highly characteristic. So this is a benign nodule. This is a characteristic of benign nodule. So this nodule would be classified as a U2 nodule. So we have discussed so far, there would be a hypoechoic nodule with hypoechoic surrounding hallo, or if there is cystic changing with the ring down artifact or comet tail artifact, or if there is microcystic spaces within the nodule, it gives rise to a spongiform appearance. So these three categories would be considered as U2 benign lesion of the British Thyroid Association. Just for the understanding, here you can appreciate a well-defined spongiform cystic lesion, cystic nodule. Mind you that whenever there is whenever you are scanning thyroid, so you should not label that as a mass. Mass is considered to be more than 3 centimeter, and if it is less than 3 centimeter, this would be considered as nodule. Normally for the thyroid we are applying the word nodule, so that you should be very careful for that. You should have to mention the nodule. So this is spongiform nodule. The next sonographic characteristic for the U2 benign thyroid nodule is peripheral eggshell calcification. If there is peripheral eggshell calcification, so this is a feature of benignicity. So look at this nodule here. This is the right lobe of thyroid, and in the right lobe of thyroid you can appreciate eggshell calcification. This eggshell calcification is a characteristic of benign lesion. So you have seen surrounding hypoechoic hallo, you have seen cystic changes with ring down artifacts. You have also seen a very particular and characteristic appearance of the benignicity is called as spongiform appearance. I have shown you multiple slides for that. Now this is another characteristic feature for the benign nodule, that is peripheral eggshell calcification, which is quite clear on this scan. This is another characteristic feature for the peripheral eggshell calcification. For better understanding, if you see more slides, you will be able to pick the points and it will retain in your minds. I see what the mind knows, you know. If you see these images time and again, you will be able to retain all these information on your brain, and at times whenever it is needed, you will be able to produce. So this is a peripheral eggshell calcification, and this peripheral eggshell calcification is characteristic feature for the benign lesion of the U2 classification. So again I would repeat here, the hypoechoic hallo with isoechoic or hypoechoic surrounding hallo, cystic changes with ring down artifacts has been discussed. Spongiform appearance of the U2 benign lesion has been discussed. You have seen peripheral eggshell calcification as well, and the last point we are going to discuss the last point now. The point which I am going to discuss now is a bit controversial, and a majority of the clinician suspect that this is the feature of malignancy, but there is a subtle changes and subtle findings. For example, if any of the nodule having peripheral vascularity, so this would be considered as benign, provided that if it all falls under the U2 features, like if it is hypoechoic with a hypoechoic hallo, like in that case you can appreciate this is a well-defined nodule, this is the hypoechoic nodule, and it is having a surrounding vascularity, so this is a benign lesion. This will fall under U2 classification. If it is cystic or spongiform, or if it is having a peripheral eggshell calcification, and with that if there is peripheral vascularity, so these all findings sometime you may be able to see in one nodule, or sometime you may see individually all these appearances. So peripheral vascularity is also a feature of benignicity. So here is another example for the better understanding. So this includes hypoechoic lesion with surrounding hypoechoic hallo, and there is peripheral vascularity. This falls under the category of U2 benign lesion. So all 5 points has been discussed. Now I will repeat it for your understanding and for your revision. If there is any hyperechoic or hypo or isoechoic lesion with a hypoechoic hallo, this would be a benign lesion. If there is any cystic changes with a ring down artifact, this would be definitely benign, but there is a name for that. You may label it as a colloid nodule. If there is microcystic changes within the lesion, or it appears as a spongiform, this would be a benign lesion. This would be a U2 lesion. If there is any eggshell calcification and it is peripherally placed, so this would also be a benign lesion. If you did find any vascularity in the peripheral region, and this would be considered as a benign lesion. Under the British Thyroid Association nodule classification, you have to label this nodule as a U2, and it is better to mention that this nodule is a benign with a benign characteristics. Next comes the category of U3, and it is called as indeterminate, because you don't really know, or you don't exactly know whether it is benign or it is suspicious. Any of gland or any of nodule, if it appears homogeneously solid and markedly hypoechoic, or maybe having a small hollow around, this would be considered as indeterminate or U3. Look at this nodule. This nodule is homogeneously solid but having a slightly hypoechoic hollow around. Usually follicle lesion happens to be with such characteristics. It does fall under category of indeterminate because it need biopsy, it need FNAC to rule out whether it is technically benign or it is suspicious gland. Look to this image. As I mentioned before, that in follicular lesion the nodules usually happens to be indeterminate. You cannot confirm that whether it is benign or it is confirmedly malignant. It happens to be solid and usually hyperechoic with a hypoechoic hollow, as you can see in this image. So this is what indeterminate nodule, and it will classify as U3. U3 nodule of the British Thyroid Association classifications, it will appear as hypoechoic. Look at this nodule. This is hypoechoic with equivocal echogenic foci. This white arrow is indicating the echogenic foci associated with cystic changes. So you might see cystic changes as separately, or you might see both features together, echogenic foci and cystic changes both together. So in this nodule, which is U3 nodule, the nodule is hypoechoic, having echogenic foci within it and cystic degenerative changes. So these both features are in this U3 nodule. Another example has been given here for the similar U3 nodule. You can see this nodule is hypoechoic, and inside it is equivocal echogenic foci can be seen, and in the surrounding you can also appreciate small cystic changes. So U3 nodules are indeterminate nodule. You cannot confirmly say whether these nodules are benign or these nodules are malignant, so in between the borderline. So still you may raise the suspicions for that. The first classification was solidly homogeneous with a surrounding hypoechoic halo. In the second, you have seen that it happens to be hypoechoic with the echogenic foci or calcific foci, or maybe with the cystic changes within it. So this will classify as U3 nodule. For the better understanding, here another U3 classification nodule is in front of you. Look at this is the left lobe of thyroid, and here you can appreciate that this is hypoechoic lesion, and within the hypoechoic lesion you can appreciate cystic changes. So if there may be calcific foci within it, or there may be cystic changes, or sometime you may see both calcification and cystic changes together. So this is U3 nodule. Another example of U3 indeterminate nodule. A nodule is hypoechoic It is in the left lobe of thyroid. It is having small cystic degenerative changes in it. However, you cannot appreciate calcific foci within it. So this is another example of the U3 nodule. U3 nodule is indeterminate nodule, and whenever you're writing the thyroid nodules, must mention the U classification, whether it is U1 or U2 or U3. So you have seen quite sufficient examples of the U3 nodules. So these were all U3 nodules. The another criteria for the U3 classification, U3 thyroid nodule, is there should be mixed vascularity. You will be able to appreciate both central and peripheral vascularity. As far as the peripheral vascularity is concerned, it is usually seen in benign if it is only in the peripheral area. But if you could notice the peripheral and both central vascularity, this would be fall in the category of U3 nodules. So here in this image you can appreciate both central and peripheral vascularity. Doppler imaging shows vascularity in the central and in the peripheral part as well. Look for another category of U3 nodule where you can find the vascularity. You can appreciate there is a central nodule within the right lobe of thyroid, although you can appreciate some vascularity within the thyroid parenchyma, but particularly focus on the nodule and the nodular vascularity. You can appreciate that peripheral vascularity is also there, and dense thick vascular signals can be appreciated in the center of the nodule as well. This is another classical example of U3 indeterminate thyroid nodule. You can appreciate peripheral vascularity as well as central vascularity. So this is a classical example. On the report you can mention that there is a mixed vascularity within the nodule, but rather mentioning the mix, it would be better that you separately mention that the thyroid nodule shows vascularity, peripheral vascularity and central vascularity on Doppler imaging. So mixed vascularity is quite confusing term, so instead mention that whether there is a peripheral or central. So mention both peripheral and central vascularity can be found on this nodule, so it is classified as U3 nodule. U4 is given to the category of nodule which happens to be suspicious. So these suspicious nodule has certain characteristic on ultrasonography. The first important characteristic is it would appear as solid and hypoechoic. Hypoechoic in a sense, if you give comparison with the thyroid parenchyma, the nodule parenchyma, it will be hypoechoic as compared to the thyroid parenchyma. Look at this thyroid nodule. The right and left lobe is visible, but on the around the isthmus, adjacent to the isthmus, you can appreciate a well-defined hypoechoic nodule, which is hypoechoic as compared to the thyroid parenchyma. Thyroid nodule is slightly echogenic compared to the thyroid nodule. So the lobe is slightly echogenic and nodule is hypoechoic, so that's why it's giving its particular suspicious look, which would be classified as U4 nodule. This is another example of the solid nodule which happens to be very hypoechoic compared to the thyroid. Always pay attention, because many a time you might miss this nodule because it will not be clearly visible during the scan, so you have to pay attention. So U4 classification is usually suspicious, and FNAC is required to look for whether it is malignant and staging of the malignancy. So U4 classification is when the nodule appears to be hypoechoic comparatively to the thyroid lobe echogenicity. So this is the first criteria for the suspicious malignant U4 nodule. Another criteria for the suspicious nodule is it will appear hypoechoic but it will be hypoechoic with compared to strap muscles. Strap muscles happens to be quite hypoechoic compared to the thyroid nodule, but if the nodule within the thyroid lobe appears to be as hypoechoic as strap muscles, so this would be again a suspicious nodule. So mind you that the echogenicity of the thyroid nodule and the thyroid lobe is very important. So pay attention. Here in this image you can appreciate that there is a thyroid nodule, but this thyroid nodule is hypoechoic with compared to strap muscles. So therefore in the surrounding muscular echogenicity and the thyroid lobe echogenicity is very important with compared to thyroid nodule. So thyroid nodule, if it is hypoechoic with compared to either thyroid lobe or the strap muscle, in both conditions it would be considered as a suspicious nodule and it would be categorized as U4 nodule. This is another example of the U4 suspicious nodule. Here you can appreciate that very hypoechoic nodule as compared to the thyroid lobe and as compared to the thyroid strap muscles. Sometimes if you do not pay attention you might miss that, and which is really it would be a great mistake, and it would be rather, I would say, blunder, because U4 nodules happens to be suspicious, and many a time after FNAC it turns to be malignant. So therefore pay attention to the echogenicity of the thyroid lobe and the thyroid nodule and also the thyroid strap muscles. Always compare one lobe with the another, and always compare, look upward and within the parenchyma, and pay attention whether there is some isoechoic or very hypoechoic nodule setting within the lobe parenchyma. The criteria for the U4 suspicious nodule is that the nodule would be hypoechoic and it would be having disrupted peripheral calcification. Mind you, there is a very important point to be noted, like if there is a peripheral eggshell calcification, this will make it a benign nodule and it will be classified as U2. But as far as U4 is concerned, which is suspicious nodule, and you will see that there will be a disrupted peripheral calcification. In this nodule, in the slide you can see like there are multiple tiny disrupted, not continuous calcification, but disrupted calcification can be seen in the peripheral part of the nodule. So this will make it a suspicious nodule. So therefore calcification is one of the very important point with respect to U2 nodular calcifications, U2 classification. So pay attention whether it is centrally placed and whether it is with the cystic degenerative changes. If it is centrally placed and with the cystic degenerative changes, it will be classified as U3. But if it is disrupted and it is placed in the peripheral part and the nodule is hypoechoic, it will make it suspicious and it will be classified as U4 nodule. Another classical example of peripheral disrupted calcification. Look for the thyroid, it appears to be hyperechoic. However, the nodularity is concerned, nodule happens to be slightly hypoechoic as compared to the echogenicity of the thyroid lobe. And the third important feature is peripheral disrupted calcification, which makes it suspicious, and it is classical U4 nodule, and it would be termed as suspicious. So write down the U4 nodule. Another very beautiful example explaining the disrupted peripheral calcification. Nodule is hypoechoic and the calcification is placed in the peripheral part. These calcifications are disrupted and these are surrounding the peripheral part of the nodule. Again, I would mention here that if the calcification is central associated with the cystic degenerative changes, this would make it a U3 or indeterminate nodule. And if the calcifications are peripheral and these are particularly eggshell calcification, this would make it benign, make it as a benign, and this would be classified as U2. But so far the suspicious nodule calcification is concerned, it would be particularly disrupted and would be in the peripheral region, and the nodule will be hypoechoic. So this is the classical example of U4 suspicious nodule. Next comes the point where you have to focus on the outline and the margins of the nodule, which will make it suspicious. In the suspicious U4 nodule, there will be lobulated outline. There will be no longer smoothness will be maintained. So this would be appear as lobular. Here you can appreciate that nodule is markedly hypoechoic. This is fitting in the one criteria, and it is hypoechoic with compared to strap muscles even. So this is the second criteria for its suspicion. And the third criteria is you pay attention to its outer margin, which appears to be lobulated. So if it is lobulated and if it is hypoechoic, so this will make it a suspicious nodule, and this is a classical example of U4 suspicious nodule. Look for the another example of the lobulated margins, lobulated outline. These white arrows are indicating lobulations, and towards the left side its small cystic places, cystic areas are also visible. But however, pay attention to the nodule, lobule and outline border. Nodule happens to be hypoechoic. Here you can see clearly that the surrounding lobe parenchyma is hyperechoic, while nodule is hypoechoic. So this is one criteria, and another is the margins. You can easily appreciate that it is lobulated margins, irregular margin. So these irregular margins making it a suspicious nodule, which would be U4 nodule. So this is classical U4 nodule. U5 nodule will be considered as malignant, obviously malignant. So what would be the criteria for that? It would be solid, it would be hypoechoic, it would be having either lobulated or irregular margins, and there will be microcalcification. These features can be seen in usually papillary carcinoma. Here on this image you can appreciate that the nodule is hypoechoic, and you can also appreciate its outlining. These are lobulated and irregular outline, and in the central part you can appreciate the microcalcification. Thyroid carcinoma is mainly happens to be either papillary carcinoma or medullary carcinoma. If there is microcalcification, this would be usually considered as papillary carcinoma, because in papillary carcinoma there will be microcalcification. So this is the example of U5 malignant nodule. Another example of the U5 malignant nodule for better understanding, have a look. This nodule is solid, and this nodule is hypoechoic. This nodule is giving some misty appearance, and because of its lobulation and irregular margin. Beside this, you can also appreciate microcalcification within it. So this is the example of papillary carcinoma, and here all the features can be fit in this nodule. So it is hypoechoic and lobulated and irregular margins giving its a misty appearance. So this is U5 malignant nodule. Another criteria for the U5 malignant nodule is it would be solid nodule, it would be hypoechoic nodule, it would be lobulated nodule, or it would be having an irregular outline and with a globular calcification. Look for this nodule. This nodule is hypoechoic, this nodule is lobular, this nodule is having irregular outline, and this nodule having a globular calcification. This is usually seen in medullary carcinoma. I have mentioned in the previous slide that whenever there is a hypoechoic nodule with irregular margin and lobulated margin, if the calcification is a microcalcification, this would likely be papillary carcinoma, and in medullary carcinoma the calcification would be globular. Anyhow, in both type of a cancer, the nodule would be hypoechoic, the nodule would be irregular, and nodule would be lobulated. So this is to distinguish between the papillary and the medullary on the basis of the type of the calcification. If it is microcalcification, so it would likely be papillary carcinoma, and if it is globular calcification, it would be medullary carcinoma. Here comes the next and very important point, and this point is usually applicable in all type of a cyst, but I'm discussing with respect to thyroid nodule. If there is intranodular vascularity, this would be considered as suspicious. Any nodule which having an intramural nodule with a vascularity on Doppler, this would be considered as malignant. So this is the criteria of the malignant thyroid nodule. Usually U5 nodule, it would be categorized as U5. So in U5 nodule, here in this scan you can see that there is intranodular vascularity on Doppler imaging. A very characteristic malignant nodule, and as I mentioned you that this criteria is fixed not only on thyroid but anywhere. If you did find any cystic nodule having an intramural soft nodule with a vascularity on Doppler imaging, always consider malignancy. So look for this imaging, and on this imaging on both sides you can appreciate the well-defined cystic lesion that is in the thyroid lobe, indicated by the white arrowheads. So this is the thyroid nodule, and here this is a cystic nodule. Within the cystic nodule, this is a soft tissue intramural nodularity. Look for the other side, you will appreciate that there is vascularity on the Doppler imaging. So within the nodule there is vascularity. So this is a confirmed malignant nodule, and it would be categorized as U5, and immediately workup would be necessary for that case. This is the same U5 malignant nodule. This is complex nodule. It would be considered as complex because whenever there is something within the lumen, so this would no longer be a simple cyst, it would be called as complex cyst. So this is a complex cyst, and within the cyst you can appreciate soft tissue nodule, and this soft tissue nodule is a feature is having vascularity on the Doppler imaging. So this is a malignant nodule. So whenever you did or you come across such type of a feature, because this image has been shown particularly for the reason that it is without vascularity, and without vascularity you cannot confirm the malignant potential. But if you put the Doppler on it, and if once you appreciate the vascularity, you can confidently confirm that this nodule is malignant on the basis of sonography and on the basis of radiology. Another criteria for the U5 malignant nodule would be its length. Its anterior-posterior length would be greater than its mediolateral length, So its medial and lateral length would be reduced as compared to anterior-posterior. It would be taller, it would not be wider. So whenever you come across any taller nodule, it would be considered as malignant. Look for these images. Here on these images you can appreciate two glands in different views. So far its anterior posterior length is concerned, it is increased with compared to mediolaterally. So this is a classical example of malignant U5 malignant nodule. So always concentrate on the its length as well, its diameter, its length, its echogenicity, its calcification and its outer margin. So when you see any taller nodule, it would be classified as a U5 malignant nodule. To explain it more thoroughly, have a look again. This is a nodule. A denotes its anterior posterior diameter, while T denote its mediolateral length. So anterior posterior length is increased as compared to its mediolateral. In other words, this is longitudinal and transverse, or you can also call it as a sagittal and transverse. So transverse length would be decreased as compared to its vertical length. So therefore pay attention to the size and also to the shape and anterior posterior length of a nodule, because it will clarify its malignant potential. To make your eyes more aware with the phenomena of tallness and its wideness, here this is another example which explains beautifully, and measurement has also been given for the better understanding. So far its AP length is concerned, on the left side it is 12.2 millimeter, while its mediolateral or transverse length is 7.4 millimeter. So it means it is taller. So whenever there is taller nodule and it fits with other characteristics as well, so you can label it as a U5 malignant nodule. Look for the another one. This is another nodule where you can see the AP is 12.8 and mediolateral length is 9.9. It's mean this nodule is taller than wider. So this is another criteria. So always consider certain points like whether it is solid or it is hypoechoic and it's lobulated or irregular margin. Pay attention to its calcification and the presence of and the size of calcification, and because it gives you a particular type of a carcinomatous appearances. And nodularity and its vascularity is also important. So this was one of the important feature which I have explained, that would be AP diameter would be greater, AP length would be greater than the mediolateral length. Another criteria with respect to malignant nodule of the thyroid is the characteristic associated lymphadenopathy. This phenomena is a generalized phenomena. It is not restricted only to the thyroid nodules, but it can be applied elsewhere. If you did find any nodule or any abnormal lesion with associated lymphadenopathy, this must be considered as suspicious, or this should be considered as malignant. So far the thyroid nodule and the classification is concerned. In U5 malignant nodularity, you will see that the nodule will be associated with multiple lymph nodes. Here in this image you can appreciate that the thyroid having a hypoechoic nodule, but in the surrounding multiple cervical lymph nodes can be seen. So cervical lymph node, as you all know, that cervical lymph node can be categorized into anterior triangle and posterior triangle, but beside this a very fine example is that it should be categorized as a level 1 node, 2 or 3 or 5. So here I'm not going to discuss about the level of the thyroid lymph nodes, but you must observe that with the nodule, with the thyroid nodule, there is associated lymphadenopathy. When there is associated lymphadenopathy, must mention on the report, and on the basis of this lymphadenopathy label the nodule as a U5 malignant nodule and mark it as red and refer to the relevant department for further workup. This is another example just to clarify this phenomena that whenever there is nodule there may be associated lymphadenopathy, and also you pay attention to the lymph nodes characteristic as well, because sometimes this malignant nodule may be associated with lymphadenopathy and it might be metastatized with the associated lymph nodes, which will further be which will further give rise to particular features like having necrotic changes within the nodule. Here in this gland you can appreciate there is a hypoechoic nodule associated with lymphadenopathy, but this lymph node having a characteristic degenerative necrotic changes. So pay attention to the enlarged lymph node, its size and also its vascularity and its also necrotic changes. This I'm talking with respect to lymph nodes. If you did find any of the nodule within the thyroid lobe, and with the thyroid lobe if there is associated lymphadenopathy, so explain the lymphadenopathy, its size, its characteristic and its vascularity as well, because it will further work it will further explain whether this lymph node is reactive to that malignant nodule or this is any metastatic, or it's may having any metastatic deposits within that. Another slide to explain lymphadenopathy associated with U5 malignant thyroid nodule. Here on this image you can appreciate there is nodule within the thyroid gland and multiple surrounding enlarged cervical lymph node can also be seen. This is very important area for the lymph node, especially when you are talking associated lymphadenopathy. So you must mention whether there is a anterior triangular lymph node enlarged or posterior triangular lymph nodes are enlarged. Or to be more specific, it would be pertinent if you mention whether the level 1 or 2 or 3 or 4 or 5 lymph nodes are enlarged. So there are certain level of the thyroid of the neck lymph node, so cervical lymph node. So therefore always mention and be specific when you are explaining. On the top of it, if you could mention that the lymph nodes are smooth or hypoechoic or with irregular margin or with vascularity or without vascularity, this would be absolutely fantastic with respect to explaining the thyroid nodules. Yes guys, this was all about the U classification proposed by British Thyroid Association, and you did notice that that was quite easy and quite understandable. You can pick all the points quite confidently on the ultrasound imaging and put it on your report. So hopefully this would be a very useful video for you. Again, I would say that the repetition is the best basis of memory, so keep revising all that so to put into your active memory. Will some new video or other informative video, we'll see each other. Till then, take great care of yourself. See you then. Bye bye.